It's a great honor to introduce both a friend, colleague, Jackie Diels. Jackie is an occupational therapist who started at the University of Wisconsin and has been at the forefront of working on facial retraining. Has been quite a bit of experience in brain plasticity and how that affects the facial nerve. And she's come up with some great techniques, and it's been great to work with her with patients over the years. So we're very honored to have her today. So Jackie, please take off.
Thank you. Thanks, Dr. Slattery. I'm honored to be asked, and always very excited to share this information because there are so many assumptions made about facial movement, and there are assumptions because we never really know how we move our face. It works seamlessly until it doesn't, right? And when it doesn't, we think, okay, what did I used to do? How did I even used to move my face? How did I move it before? And so hopefully I'll demystify some of that and give some ideas on how to treat these patients. I'll give some information about how I treat patients, but a lot of what I want to do today is explain how I assess the patient, because I think that helps the doctors and the therapists and the patients understand the underlying issues that are associated with facial nerve disorders. So it's hard to believe, Dr. Slattery, that I was at the University of Wisconsin for 32 years and finally saw the light, and I'm now in private practice. I kid just a little bit, and enjoying it, even into this time of COVID. And there's lovely Madison, Wisconsin there on the screen. What am I on? All right. So facial retraining is an advanced practice clinical therapy program designed specifically for facial nerve disorders that are caused by peripheral injury to the facial nerve. So not caused by stroke, for example, but by actual injury to the facial nerve. The program, I was very blessed really to be mentored by Paul Bocchierita and Richard Vallier at the University of Wisconsin. And they're pioneers both in the field of brain plasticity and facial neuromuscular retraining in general, but then specifically facial neuromuscular retraining. So the etiologies I see are basically the same etiologies as what you all see: post schwannoma, other skull-based tumors, viral causes, Bell's palsy, Ramsay-Hunt, trauma, Lyme disease, which is prevalent in Wisconsin. We see some congenital patients, and then all sorts of surgical reanimation, post-surgical reanimation patients. And here I wrote no CVA. We don't see patients who have CVA where facial paralysis is caused by an upper motor central lesion as opposed to the peripheral neuropathy. So what do we see in this gentleman? What is he expressing to us? And so if I were there with you, you'd all be shouting out answers to me. Well, he looks upset, or he looks depressed, or he looks a little bit angry. Now what would you say? He looks happy. That patient has unilateral facial paralysis. So this is his unaffected side, and this is his affected side. The two sides of his face essentially communicate different experiences. And one of the things I think we don't talk about is the fact that the facial muscles are communicative muscles. So the facial neuromuscular system has a very different job than other muscles that therapists typically work with. So they work with bicep, tricep, musculoskeletal injuries. And those muscles are not mediated at all by the emotional centers of the brain, whereas the facial muscles are totally mediated by the emotional centers of the brain. And so this patient not only looks happy or sad on both sides, but he feels it and he communicates that to the onlookers. And so patients are often very self-conscious, very depressed. There are a lot of emotional issues that go along with facial paralysis. So what do we need for communicative facial expression? We need adequate strength. So if there's a flaccidity of the face and we don't have adequate strength, we're not going to have good movement. We need soft tissue mobility. So if there are contractures or spasms in the facial muscles, we're not going to have good movement either. And we need precise coordination amongst the 23 plus muscles that create various facial expressions. Without the coordination, we don't get good expression. So from the therapy perspective, and I touched on this a moment ago, we're working here with a peripheral nerve versus an orthopedic or musculoskeletal injury. There's either a lack of nerve conduction in a flaccid patient, or in a delayed recovery situation, you can get aberrant nerve conduction that causes abnormal movements. The facial muscles are unique in the body, and in that they move skin. Like, whoever thinks about that? They don't move bones around joints. They don't move or lift heavy objects. They simply move skin. I can move my bicep. If I flex my bicep, I'm moving my bone. I am not moving my skin. And so it's hard for the patient to understand sometimes that they're not just kind of trying to exercise their muscles and get them strong, but we have this variability in movement that's created by the different expressions that are created by the various movements of the facial muscles moving the skin. Facial retraining is often counterintuitive to other therapy interventions because increased strength does not necessarily improve movement or expression. And so, I've been talking to you for a few minutes and I'm kind of just talking normally, but when I was introduced, I didn't say, "Oh, thank you so much. I'm so happy to be here." We don't move our face big. We move it in many ways. We have great breadth of movement, but we don't have great amplitude of movement. So facial expression is never a high amplitude movement, but very subtle, low amplitude, and again, very coordinated. The misunderstanding of this concept leads to a misalignment of the disease process, what happens, and the therapy provided. And that often results in poor outcomes and dissatisfaction on the part of the patient. The facial muscles themselves are different from skeletal muscles. They lack muscle spindles. So a muscle spindle is a physiologic mechanism within the muscle that responds to various forms of stretch, vibration, tapping. So certain modalities elicit a contraction of the muscles. But because the facial muscles don't have them, those typical modalities used by therapists don't work in the facial muscles. They're highly resistant to fatigue. They're slow to atrophy. They have very small motor units, which allows for a great deal of specificity in how the face moves. And they have soft tissue. Most of the attachments of these muscles are soft tissue attachments. So the muscles attach to the soft tissue of the face, and they're like a woven fabric, especially in the lower 1/3 of the face. They're like a woven fabric. So it's even difficult to dissect one from the other in some cases. And like I said before, they receive emotional as well as volitional cortical input. So the retraining program is based on post-acute rehabilitation, and that is after the nerve begins to recover. And I'll cover that a little bit more in a minute. It provides continuity of care after facial nerve injury from whatever cause, and especially after surgery, acoustic neuroma surgery, where the patients are just, they're waiting. They're waiting for their nerve to recover. So we provide continuity of care for those patients. It relies on new learning versus simply spontaneous recovery. We work with coordination and precision as opposed to strengthening and mass movement. And we see patients intensively in the clinic periodically. It's not the kind of program where we'll see a patient 2 or 3 times a week. Depending on where they are in the program, we may see the patient once every 6 weeks, once every 2 months. But in the meantime, they are practicing a very specific home program on their own at home that has been developed specifically for their facial function. Everybody's face is different. Well, our faces are all different to begin with. And our faces are more different than our elbow joint is different. And so everybody gets a tailor-made program based on their own function, based on their understanding of the disability, based on their psychosocial, the psychosocial impact that the disability has had on them, and based on their aptitude. There are 4 main functional categories of patients that I work with. So we have the flaccid, the flaccid patient, which is the one that we think of most often when we think of facial paralysis. We have the paretic patient, where the movement is just beginning to return. It's just beginning to come back. And then we have the synkinetic patient, where the patient has abnormal movement caused by what's thought to be misdirection of regrowth of the facial nerve during recovery. And that is the bulk of my caseload, is with the synkinetic patient. And then there's another entire group of post-surgical reanimation and reconstruction patients. I'll be touching on that very, very briefly today. That's an entire concept all unto itself. So in a typical delayed recovery after an acoustic neuroma, and this young lady had an acoustic neuroma, we see a sequence that's quite typical and predictable if recovery is delayed. And this gal's husband took these pictures as she was recovering. This is 10 days post-op, and you can see she has a droop of flaccid paralysis on her right side. And here's 2 months. We're starting to get some good recovery where the angle of the mouth is coming up. At 4 months, her smile looks quite good. And so she's on her way. This is interesting to me, though, because if you look at the mid-face, on her left side, you can see that she has good bulking of the mid-face and the zygomatic muscles. But on the right face, she doesn't have nearly as much bulking in that area. And yet, we still see full teeth show there. So you can see that you don't need full 100% strength of the muscle in order to achieve a full smile. So this is very interesting to me. because you would think that you needed to have an equal amount of activity on both sides to achieve this type of a smile. So this is 4 months. At 6 months, we see she's got good bulking of the cheek. The angle of the mouth is definitely up, but there's some kind of a change happening here. And at 15 months, well, let me just back up a second. At 14 months, I got the phone call. Hi, I was referred to you. My face, after surgery, it was getting better and better and better, and now it's getting worse again. And so you'll hear that terminology, and I'm sure you've all heard it. Now it's getting worse again. So when she came in for her initial evaluation, she looked like this. So what happened here between 4 months and 15 months? At 4 months, we have almost full teeth show. Now we're seeing less teeth show, deeper nasolabial fold, quite bulky cheek, especially compared to how it was at the 4-month point. So what's happened in this period of time that causes her to think that she is getting worse again? So what the patient is thinking is that they're regressing back to how they were in this time frame, at the beginning time frame. So what happens depends on how you look at it. So if we look at this illustration here, you can look at it in 2 ways. And if I saw a show of hands, I would ask how many people see a face in this, right there, and how many people see a woman walking in a park. Depending on how you look at it, you'll come up with a different answer to the question. So how do we look at the face, and how do we interpret this facial function right here? At first glance, to the uninstructed eye, it looks like they have the same thing, right? You look at their face, a quick look, the angle of the mouth is down. In both cases, it looks like a facial droop. And yet there's a very different quality about it. So let's look closer. So on this gentleman, we can see that there's a flaccid paralysis. The eye is a giveaway here, right? So we've got quite a ptosis here at the lower eyelid, but we have no bulking in the cheek at all. And if we look at the lady, we see that she has a very very tight cheek, and so tight, in fact, that it's actually shiny. And then there's a sort of a strange pattern going around the brow, where the affected brow is actually higher than the unaffected brow, as opposed to the gentleman whose affected brow is lower than the unaffected brow. Let's look further. If we look even closer, we can see that we've got this droop here at the angle of the mouth and this jowling occurring here. And in the woman, we can see these very tight cords of the platysma muscle. So we've got platysmal banding that is pulling down and depressing the angle of the mouth. And that looks like this. So we have opposite situations here. We have a flaccid paralysis versus a synkinesis. They look at face glance, they look like they're the same thing. So the interpretation of what's going on with the patient is incredibly important to providing the right kind of therapy for these patients, because really they need opposite things, right? The gentleman needs stronger muscles, and the woman needs better coordination and a decrease of synkinesis. And I hope that this makes sense. I don't see anybody's head nodding, so I'm going to assume. And here we see in a pucker movement, the gentleman doesn't have any flexion, especially of that upper lip during the pucker. But if you look at the woman's mouth, and if you disregard the fact that everything is shifted toward her synkinetic side, the mouth is actually quite round. The angle of the mouth is being depressed by both the platysma and the depressor anguli oris. And we can see that the shift of the philtrum always goes toward the stronger side. And in a synkinetic face, that is often the synkinetic side being the stronger side. So here we see she's got synkinesis of the upper cheek, the levators, the zygomatics, probably buccinator, and the depressors and platysma. So what do we do with these patients? So for the flaccid patient, early intervention is eye care. So making sure that their eye is healthy, protected, lubed, making sure, especially in a severe case like this, that the patient is being followed closely by ophthalmology. There are various techniques that we can help the patients with, such as how to patch their eye, how to tape it up from the bottom, always following the ophthalmologist's instructions for that. We teach them gentle stroking and this is for sensory awareness, where the affected side of the face is not sending any movement signals to the somatosensory cortex. And so the brain isn't getting the signal that the muscles are there or that the face is alive. And so by stroking, we're at least maintaining some sensory input to the brain. And that has been shown in rat models to improve the outcome as the nerve regenerates, so that the rats had less synkinetic whisking movements with a recovery after a nerve transection and repair. This is not intended to stimulate movement at all. It just provides that sensory input. And then my advice to the patients is to let it heal. If there's no innervation, there can be no exercise, because there isn't any neural conduction. So if there's no signal getting through to the muscles from the brain, no matter how many times you try or how hard you try to move those muscles, they will not move. When a patient tries to move their face in a very efforted way, what they're really doing is they're increasing the asymmetry by hyperactivating the unaffected side. And so they're actually decreasing their symmetry even more, strengthening the unaffected side, and habitually learning some bad patterns. I use analogies with the patients, because every single patient that we see after the diagnosis of Bell's palsy or paralysis after acoustic or whatever, they're going to go home and they're going to just try to crank that thing and to move it as much as they can. And so I will use analogies with them. And I think that these are really helpful for the patients to teach them what they're dealing with, because they look at it as a muscle weakness, as opposed to lack of conduction. So what I'll tell them is, it's kind of like if you have a lamp on your table and you unplug the lamp, how many times will you have to flip the switch for the bulb to go on? And so that gets their brain thinking in a slightly different way, that, oh, yeah, it can't possibly work right now. That nerve is going to take X number of weeks or months to heal. Another analogy that I'll use with some people is if they've broken their leg, for example, and it's in a cast, what kind of exercises are they doing to strengthen their leg muscles or to strengthen the bone? And of course, they're not doing any exercises. They're allowing that to heal. And so speaking in analogies, I think helps the patients kind of calm down. And with Bell's palsy, for example, given the fact that 80 to 85% recover completely and spontaneously within 3 months, they have a time frame where they're just letting it heal and letting it rest. We begin retraining when, actual retraining when tone increases or there are small movements evident. No electrical stimulation ever with any category of facial paralysis. So the research findings are that it's not effective in treating facial paralysis. So number one, right off the bat, not effective. Some animal studies were done in, I believe it was in the 70s and 80s, that showed that it may interfere, stimulation may interfere with the development of the growth cone and neural reinnervation. It can reinforce abnormal movement patterns by activating and stimulating more muscles than are intended in a normal isolated sort of facial expression. It doesn't train function. E-stim doesn't train function and it doesn't train expression. It just flexes a muscle. We find anecdotally, those of us who've been in the field for a long period of time find that electrical stimulation causes more mass action and abnormal movement patterns than patients who don't get electrical stimulation early on. And it doesn't generate an emotion. And we really have to pair, in facial retraining, we have to pair the emotion with the motion. So I always tell patients that facial expression doesn't come from a place of motion, it comes from a place of emotion. And it's really important to for them to grasp, and for us all to grasp that concept. For late intervention on flaccid paralysis, we'll initiate at the point in time where we think we should be seeing either full recovery or at least partial recovery. So with Bell's, that would be 3 months. For acoustic neuroma, I have 12 months here, but I think that there's definitely some debate on that. And I've actually changed that. I need to change this slide. But I'll start to see patients post-acoustic at 5 or 6 months. And I know that with a lot of the new surgical reanimation techniques, those are actually being done in that time frame. And so we're having a lot of discussions right now about when is the proper time to surgically reanimate the face. And those are discussions that we won't get into here today. With late intervention, we focus on symmetry of movement. So if the patient has a little bit of movement coming back, we use that little bit of movement and have the patient recreate that movement just to the extent that they can do it easily. So their brain relearns the pattern of movement without going into a movement that is done with more effort than can be easily achieved. Because if a patient starts to move too forcefully, they'll pull in overflow from neighboring muscles. We teach precise movements using sensory feedback. We sometimes use EMG biofeedback for evaluation and training in this period of time. And then I mentioned surgical reanimation. If a patient has gone, in my practice, if a patient has gone 12, 13, 14 months and is still completely flaccid, I feel they need to be assessed for surgical reanimation. Here's my patient, Paul. Paul had Bell's palsy. This was Paul in November of 2002. And you can see he's completely flaccid. His eye was just a mess. And even though he was seeing an ophthalmologist, he wasn't very good at following the protocol. And so very concerned for him, but he did well. So, so here he is in 03, and this is actually the picture that I showed when I did the comparison between this and the synkinetic lady. And here he is almost 3 months, or I guess actually just over 2 months post. And you can see that he's starting to gain function. I was not actively seeing him in this period. I was just having him come in to monitor, because if there's no movement, then there's no exercise. And so I was trying to help guide him with his eye care, but we were not doing any active movements at this point. And he is recovering. And then in May, so 6+ months later, he looked like this. I would love to sit here and say, this is what facial retraining does, but this is spontaneous recovery. It's delayed. He is a little bit delayed. And if you look closely, you can see that he did develop just a little bit of synkinesis. We've got a tight platysmal band here, and we've got a little bit of synkinesis in the affected eye when he puckers his mouth and when he smiles. But this is spontaneous recovery. And this was the end of his treatment. He was very happy with his outcome. So that's the story of Paul. Paresis is when movement is starting to come back. We're starting to see tone. Symmetry is increasing, and there's no synkinesis. And I have yet in parentheses, because if it's a delayed recovery, there will be synkinesis. There will be synkinesis. And here's a very nice lady, post-acoustic, who came in. She was about 2 years post, and this was her initial evaluation on day 1. So at that point, we had people coming in for 2.5 days of treatment, 12 hours over a 3-day period of time in the clinic. And this was her initial evaluation on day 1. You can see she has good pucker, pretty good pucker. No real synkinesis. A lot of difficulty finding her mid-face here. She did have a little bit of nasolabial fold coming back, so I knew that she had movement and she was reinnervating, and yet she was having trouble, I would say, locating her muscles. And then on day 3, this is what she looked like. And it looks like a miraculous recovery in 2 days, but really what happened through the retraining process and the education that's provided, she was able to find her muscles. And because we don't know how our facial muscles move in before we have paralysis, so we all know that volitional facial movement is different than spontaneous, right? Because how you look in a photo when you smile is not the same, usually for most of us, as it is when somebody catches us smiling spontaneously, right? So it's different. It comes from a different part of the brain. And so when I was able to teach her where the muscles were and have her focus on her unaffected side and how it moved on the unaffected side, how it felt on the unaffected side. And there's a way that we guide patients in this way. She was able to learn how to access the muscles that were there, that had come back. I can't see any of you, I don't think. Let me just see, maybe I can, no. But I'm gonna actually have you try this on your own while we're sitting here talking about this paretic face. So if I ask you to wrinkle your nose up as though something smells bad, I call this the snarl, and you're accessing the levator muscles here. And assuming that none of you have facial paralysis, when you do that bilaterally, you can, thank you. When you do that bilaterally, there's really no problem accessing those muscles bilaterally. So now everyone try doing that on the right side by itself. And now everyone try doing it on the left side by itself. So Dr. House, you're a lot better on your right side than your left side, right? So here's the question. Why can we do it bilaterally? No paralysis, no issues. And yet most of us, and I've done, this is not a real study, but when I'm giving lectures to student groups, and there are 100 students in the lecture hall, and I do this with them, typically it's 3 or 4 out of 100. That's my unscientific research. 3 out of 100 that can access, they can isolate each side independently. So what is it about our brain that can access one side and not the other when we know we have full movement? And so these are the things that I teach patients. Do we have a neural connection? And why can't they find it? And I teach them how to find it. And Dr. House, next time we're together, I will teach you on your left side how to find that muscle. It's really interesting because we always assume if we don't see movement, it must be paralyzed. But very often it is that the patient can't find the address of that muscle. And here is a patient. This patient was 26 years post-Bell's. And she's smiling, and she was being evaluated for facial reanimation, surgical reanimation procedure. And the physician sent her to me first just to see what my input would be. And she clearly has tone. You can see she has a nasolabial fold. It looks like she's drooping, but this, in the absence of jowling in this aged woman, to me indicates, rather than a flaccid paralysis, which we know she doesn't have anyway because she has the nasolabial fold, right? But no jowling. So to me, this indicates synkinesis of the depressor anguli oris. So that's just a little downturn at the angle of the mouth. So this was her initial evaluation. Actually, I only saw her one time. And I had asked her to smile with her lips apart. And then I told her something very simple. I said, okay, now I'm going to ask you to do it again. This time, instead of smiling with your mouth, I want you to smile with your cheeks. And this is what she did. Patients don't know that the smile muscles are located in the cheeks and they lift. And the bottom of the smile muscles, the inferior aspect, attaches to the angle of the mouth. And so when the zygomatic muscles flex in the cheek, they raise the mouth. The mouth does not make the motion. And so this was sort of an astonishing thing. And it was astonishing to her too. And so we worked for a little while, and she went on to get Botox to deal with some of the synkinetic issues. But it's really, it's a very interesting case, isn't it? Just by giving the patient a different way of thinking about it, we can access the movement in a different way than they had been doing before. Synkinesis is the biggest group, patients with synkinesis, that's the biggest group that I work with. So synkinesis causes abnormal synchronization of facial movement where muscles other than the ones we intend to move are contracting simultaneously, causing distortion in expression. The distortion often looks like a flaccid paralysis, but it can actually be depression, active depression during active elevation. And so because the muscles move the skin is going to move whichever way the muscles are flexing. So what we do in the treatment of synkinesis is suppressing or inhibiting, relaxing the synkinetic movements, and that in turn decreases the distortion, improves coordination and functional movement patterns. Synkinesis is almost always misunderstood. And that can lead to ineffective and inappropriate therapy. And for therapists who have been in the field for a long time, they have not been trained in facial movement at all. In terms of a therapist's caseload, most therapists go their entire career without ever seeing anyone with facial paralysis, and even flaccid paralysis, let alone synkinesis. And so what they do is they take the techniques that they've learned in school and they apply them, such as electrical stimulation, they apply them to what appears to them to be a flaccid paralysis. And it's important, and when I teach therapists, just reinforcing this concept that this is a peripheral neuropathy that causes neuropraxia, in most cases where there just is no nerve conduction. And then in synkinesis, we have this aberrant nerve conduction caused by what's thought to be that aberrant regeneration of the nerve, causing wrong connections. And that the limited excursion is the result of a lack of mobility and coordination, not a lack of strength. And this is very counterintuitive to other therapeutic interventions. And again, like I said before, increasing the strength does not increase movement and expression. So somebody who has synkinesis, typically when they increase their strength, they also increase the synkinesis, which further limits the excursion and decreases the overall expression. There are 3 parts to the training of synkinesis: patient education, soft tissue mobilization, and coordinating movement patterns. Patient education is absolutely key for them to understand where the muscles are, like you saw in that the patient that I showed where I had her flex her cheek muscles. Just knowing where the smile muscle is located. Where are the muscles located? What do they do? This is all basic stuff that we never learn because facial movement is by and large emotional and spontaneous. How do the muscles coordinate for expression? Each muscle has a singular biomechanical action and also a singular emotional signature. So the zygomatic muscles don't contract when we're sad, right? So if we're happy, we flex zygomatic. If we're happy, we don't flex depressor angulioris or levator. Soft tissue mobilization is foundational to these synkinetic patients because they typically have contracture and spasm in the muscles. And the muscles are hyperactive and tight, and a tight muscle does not move well. And there's a wide range of different soft tissue mobilization, stretching techniques that we teach the patients depending on where their the tightness and contracture is. We teach the patient that the abnormal movement distorts the expression. And here you can see on this picture, this is Emily, and she's smiling. You can see she has very good mid-facial movement, but she also has, in the red arrows are designating the synkinetic areas. And so she has a lot of restriction that's caused by the skin being pulled in multiple other directions than where she's intending to go. We do this detailed vector analysis with the patient in real time during the evaluation. So I do this on a laminated sheet with the muscles, and I ask this question of the patient. When we do the I have the green arrows designating the movements I'm asking the patient to make, and then the red arrows designating the movements that are also occurring that are not occurring on the unaffected side. And then I ask the question, so Emily, which side is actually moving more? And she stops and thinks, and she looks and she says, my right side. And I look at her and I'll say something like, so how weird is that? If that's your paralyzed side, why is it moving more? And then I have the opportunity to explain that the therapy we're going to be doing for the synkinesis is one of subtraction rather than addition. We're going to inhibit and decrease those red arrows, those movements, in order to allow the movement that we're asking her to do to go through a more normal range of motion with no restriction, with no antagonist pull on the skin in a different direction. So we work with precision here, not power. And this concept Dr. Slattery mentioned before, brain plasticity, finding the address of the appropriate muscles. This is like learning how to golf. We're not making big movements necessarily, but we're learning small, sequential tasks that we practice in order to improve the whole. The more the patient understands about the vectors, the better they'll do. The better they'll do. They'll stop trying so hard, because in a synkinetic face where the angle of the mouth is depressed, what they're doing is they're trying as hard as they can to get the angle to go up by moving their mouth. And that doesn't work. An important and overlooked muscle is the buccinator. And the buccinator muscle is one muscle. It's located in the mucosa, so it's deep in the face, and it is a facial muscle, but it mostly assists in maintaining the food in the oral cavity as we eat. The action of the buccinator is it retracts the angle of the mouth, but it brings it close in to the teeth. In doing so, it closes the angle of the mouth. And so if I flex my buccinator, it does this. It basically clamps the angle of the mouth shut, which is great while we're eating because we don't want food to fall out, but not so good while we're smiling. So if I smile and I flex my buccinator, watch what happens. And you'll see my smile muscles don't change, but watch what happens. So loose, tight, loose. And so when a patient uses a mirror, which I don't use, by the way, we use proprioceptive internal feeling rather than visual feedback. They see that the corner doesn't go up, but they don't feel that the angle of the mouth is retracting in against the teeth. But let me show you what this looks like. So here's a patient post bells with synkinesis. I'm having her close her eyes, and you can see the buccinator contracting. And now I'm having her smile, and you can see this very significant contraction of buccinator that's limiting her ability to open her mouth during her smile. That is compared to her unaffected side.
Open.
And closing the eyes, nothing going on here.
And smile.
And nothing going on with her smile.
And jaw open a little and smile again. And release.
So for this movement coordination, movements are small because they mimic normal expression. We want to recreate normal as much as possible. We're not trying to overextend the muscles. We want to get normal expression, and small amplitude movements achieve that. Slow. At the beginning, we do them slowly so the brain can find its way. What am I trying to inhibit? What am I trying to activate? Inhibiting the synkinetic muscles, teaching the patient what not to move as opposed to what to move, and using that proprioceptive feedback, like I mentioned before, to feel what is not seen by the eye. This is also helpful in practicing the home program because then the patient can do it anywhere. And we use the unaffected side as the model. So the proprioceptive feedback increases accuracy. It also minimizes the negative emotional response that patients get when they look in a mirror. So a patient with facial paralysis is not happy about looking in the mirror. They don't like what they see. So this takes away that, totally sidesteps this negative emotional experience response, and it incorporates easily into the home program. We attend to the unaffected side to model the movement correctly so that the brain can relearn, that's what I'm trying to achieve. That's the ease that I'm trying to achieve. I think I just talked about this, but one thing I do here that I want to mention is midway down here, I ask the patient how small they can make that movement as opposed to how big. How small can you pucker your lips and still know you're puckering? And here's Emily. Emily did not have Botox at this point. She did go on to have Botox later, but this is a year of working on retraining. And so it's improved, it's better. It never is 100%. I don't know of any technique, including neuromuscular retraining, that can restore this to a patient to 100% function again. I'm looking at the time. So, well, I'm going to go ahead and play this. Let's see. All right. So this is patient 18 months post Bell's palsy. I'm having her snarl. You can see that she's activating her levators, but having trouble finding them. And at the same time, bringing in platysma, mentalis, oculi.
Try it again with your eyes open.
And she's working really hard to achieve this. You can see that.
Interesting. Okay.
And then here's 3 months later, where she learned how to isolate this muscle.
And release.
And no Botox on this patient either. This is a patient that I saw, and this is just one very, very brief case of somebody who had a masseter muscle transposition. I saw her 3 months. I didn't see her. This is the picture 3 months before surgery. She was out at a bar with her friends after work. And this is 5 years after surgery, which is her initial evaluation with me. The op report, this was a long time ago. The op report was unclear, but I think that her facial nerve probably was sacrificed and it was not repaired. At 5 years post, with a flaccid face like this, there was really nothing that we could do for in terms of retraining. And she went on to have a masseter muscle transposition, and she's biting to achieve this. And this is one of many reanimation techniques that are available right now. So she looked much better. This is interesting. You can see a little line here on this this picture here. Her local town did a newspaper story on her and her recovery. And this was a clipping from her newspaper that she sent me, which was, I think, really great. We do use Botox and facial neuromuscular retraining Concurrently, I like to work with patients with retraining first to teach them some of these techniques, and then we can use the effect of the Botox to further help the brain learn more appropriate movement patterns. So this is Guy, and he had Bell's with Synkinesis, and you can see he's got a really significant platysmal banding and depression at the angle of the mouth during smile, during pucker. And I often will help assess the patients with the retraining patients where I'd like to see the Botox injected so that we can maximize their retraining after they had the Botox. So this was his Botox plan. And then this is how he looked. This is some photos he took at home and sent to me about 2 weeks after his Botox injection. So it works really, really well. And it does seem to improve the motor learning. So when to refer? For a viral, post-viral, Bell's palsy, Ramsay-Hunt, if they're not fully recovered by 3 months, go ahead and refer for neuromuscular retraining. Skull-based tumors, it's going to be very, very individual. Well, it's across the board, as you know. As soon as there's a little bit of movement, I mean, unless movement comes back a week later, then we're not going to have to see those patients. But if they've gone 3 months and they don't have full recovery, we let it recover just a little bit more, maybe at the 5 or 6 month point, go ahead and refer. For the reanimation procedures, it really is procedure dependent, depending on which procedure is done. We'll see faster reanimation with a mesenteric transfer, for example, than we will with a cross-face nerve graft. When you're writing a script for a patient who has facial paralysis, whether it's flaccid paralysis, and in those cases, the therapist should be doing mostly education and eye care. If you write on the script, facial retraining, post whatever the etiology is, no e-stim. Write no e-stim, otherwise most of the therapists you send patients to will do e-stim on these patients. The overall frequency and duration of treatment is 18 months to 3 years. It's a long program. It really does take time for the brain to learn. They are working on it daily. The clinic visits decrease as the patient becomes proficient. Maybe in the last year, I'll see a patient once or twice, and that's all. We teach the patients to become their own best therapists. We teach them how to analyze themselves. And we've estimated that about 90% of the treatment is completed by the patient on their own at home through the home program. We videotape and photograph the patients. We've found in general, they improve 1 to 2 grades on the House-Brackman scale. I would say obviously nobody gets to a grade 1. Somebody who comes in at a grade 4 or a 5 will get to a grade 3. We sometimes get people back to a grade, get people up to a grade 2. But we're in that category where, you can talk about a high 3 and a low 3. It just depends how well they do with the synkinetic reduction. A nice study that was done by Ross and Nidzalski showed that gains that were acquired through retraining were retained even after the patient stopped doing the retraining. And we need a lot more studies in this field to demonstrate its effectiveness. So in summary, facial neuromuscular retraining is very much a patient-centered program providing good continuity of care. It's cost-effective in that the patients are seen at long intervals between treatment. They're not seen frequently in the clinic, and it provides specific retraining based on the unique characteristics of the facial neuromuscular system. I don't know who said it, but it's true. Facial muscles are the only ones whose principal role is to move other people. Thank you so much for inviting me. I think maybe we don't have time for questions, but if we do, I'm really happy to take any.